All right, good afternoon, everyone. What a privilege to be here. I want to thank Dean and Sharon for the privilege of the podium. So why do they want me to talk about data? Why is this important? Just a quick refresher. Everyone here did this, but with retrospective studies, we're looking backwards in time, right? It's truly observational, and you don't know if you have one of Vedra Augustein's disaster hernias here on the side, or my nice central hernia here, right? We have a very diverse, heterogeneous population that you're studying. You have no control over it. But we want data. We want to prevent on the end from happening. We don't want to have, oh, what just happened? So in going forward with prospective studies, you're not going backwards trying to scramble and get data, right? You're actively collecting it, but it's still truly observational. You are not doing an experiment. This clicker is not good. Let me go back. Okay. So a randomized controlled study, it's an experiment. We are saying what we want the conditions to be. We're looking at a hypothesis, and at the end of the study, we want to know if what we found is true or not to help guide us in patient care. So if you look at hernia mesh, there's actually a good amount of papers out there, almost 11,000. To focus it down a little bit, I decided what we're going to look at for the next 10 minutes or so is randomized controlled trials, the gold standard. And there's actually 576 of them if you filter through PubMed for randomized controlled data. So we have to have a way to decide what to talk about today. And in thinking about which mesh, it's not necessarily just the material itself, right? That is important, the type of prosthetic mesh, whether it's synthetic, a synthetic resorbable, a biologic mesh, but you want to think about the environment. Is it clean or contaminated or dirty? You want to think about the type of repair you're doing. Is it lap? Is it open? Are you closing fascia? Are you bridging? Are you maybe even putting in mesh prophylactically? And then finally, where's the location of your mesh? Is it an onlay? Are you behind the muscles? Are you in the preperitoneal or the intraperitoneal space? And there's more questions we still don't know. How long do we need mesh to be there? That's a question I've been thinking about for years and we still don't know the answer to. So the first study I want to talk about is out of Washington University, where they're looking at the impact of technique and mesh type in a randomized controlled trial looking at complicated ventral hernia repair. So in this study, they wanted to determine whether an onlay technique versus an underlay technique was better. And these are only in patients with component separation. So in this population, they're specifically choosing patients who they think need to be closed, can't be closed primarily, and need to have an underlay. And this was a double-blind, randomized controlled trial. Not only did they compare a retromuscular mesh placement to an onlay, both of them with releases, the onlay with a Ramirez, the anterior, retromuscular with a Reeves or a Tar, but then they also looked at the question of which type of mesh was better. And in this case, it's specifically biologics, a human versus a porcine. So in their follow-up, they had 90% of their patients at a year, and their overall recurrence was 10%. There was really no difference between the groups. Not shockingly, the group that had the anterior onlay had a much higher seroma rate and a higher SSI rate because of the big flaps that have to be dissected. And then in looking at the whole study, again, their recurrence rate wasn't different between any of the groups. As we said, the seroma rate was different. And interestingly, the infection rate was lowest in one of the overlay groups, which doesn't make sense when you think about the fact that there was a higher seroma rate. But in this head-to-head comparison, so although the techniques were different, the outcome was the same. The patient was closed at the midline. Using biologic mesh, it didn't matter which one, you had the same outcome. It was a relatively short follow-up, and they did have an overall recurrence rate of 10%, which when we're thinking about like a gold standard repair like this with a component separation, you would hope it would be a little lower. So you have to wonder, is a biologic mesh really necessary in this setting? So that brings me to the next paper, synthetic versus biological mesh in lap and open ventral hernia repair with the LAPSIS. All these papers have to have their fancy acronym. And this was under the auspices of the European Hernia Society. It was actually performed about a decade ago, but they're just publishing now. The primary aim was to look at the optimal surgical approach, laparoscopic or open. And then they also stratified it by the most suitable mesh, biologic or synthetic. And this was in elective, non-contaminated ventral or incisional hernia repairs that measured between 4 to 10 centimeters in diameter. This was done with our current gold standard technique with 5 centimeters of mesh overlap. However, they didn't close the fascia on the laparoscopic group, which I think most of us would do today, and it's very important in terms of looking at the outcomes of this study. So they were following patients up for at least 3 years, and this was a double-blind, randomized controlled 2-by-2 study that was performed in 10 different European countries at 17 different centers. So a lot of different surgeons. So you can see the groups. They attempted to close retromuscularly. There was no component separation, though, and there was bridging in the lap group. So when they looked at the groups and they looked at the complication rate, they had similar numbers in the groups, but they were actually stopped before they got to their recruitment number. They were supposed to get 660 by their their preliminary analysis, but at around 253 patients, their data monitoring study stopped them because of higher preliminary recurrence rate in the biologic group. So here is that Kaplan-Meier curve. Both the lap and the open had significantly more recurrence in the biologics. So 10% versus 25% at all primary endpoints here. And the recurrence rate was 3 times higher in biologics. That was primarily in the laparoscopic group, which I think most of us would conclude is because you were bridging a defect with a biologic mesh. And we've had numerous studies now that say that's really not the best way to use that material. You are going to have a high recurrence rate. But these were clean cases, and the synthetic mesh performed equivalently in both lap versus open, so the technique did not matter for synthetic mesh. And as I mentioned, both biologic groups had higher reoperative rates and higher rates of recurrence. The next study is looking at preventing recurrence in clean and contaminated hernias using biologic versus synthetic mesh and ventral hernia repair. It's called the PRICE randomized controlled trial. And this is out of University of California, San Francisco. What's interesting about this paper is they really emphasized that this was a pragmatic clinical trial versus an effectiveness clinical trial. So in your effectiveness trial, you're really controlling to have ideal circumstances. And in this case, they wanted it to reflect their real world practice. So they actually had a very wide variety of different types of techniques and situations in this paper. It was single-blinded, randomized controlled, and they wanted to compare biologic versus synthetic mesh. And they used a non-cross-linked porcelain acellular dermis. For intraperitoneal mesh, it was a mid-weight coated mesh with a resorbable hydrogel, and extraperitoneal, it was a macroporous mid-weight. And the variable mesh placement, sometimes they had fascial closure, sometimes they bridged. It was a pretty wide group. So 63% of these patients were there for a primary hernia, for a recurrent hernia. And they had, for the inner city, pretty good follow-up. I mean, I think 76% follow-up at 24 months in San Francisco is pretty good for the United States. We are not a socialized healthcare country. So when you look at recurrence, again, it was much higher at 2 years in the biologic group, 40% versus 14%. And a lot of that occurred in the contaminated group, which is really interesting, right? Because we think that biologics we should be using in dirty fields. But this study showed that actually there was a much higher recurrence rate in those dirty fields in the contaminated group, and they had equivalence between the two groups of patients in the different classes. So you can see the wound class breakdowns here, and there was no statistical difference between them. They had 6 explants, 5 of them were in synthetic mesh, and all of them were at least a year out, so it was usually for a chronic mesh infection. They did have to take out 1 biologic for an EC fistula. So in this pragmatic study, a busy urban hospital, they showed a much higher rate of recurrence in biologic mesh, although the power didn't discriminate between the different types of repairs. But it does support using synthetics most of the time. And then just a quick review of actually putting mesh in now before you have the hernia. This is a recent randomized controlled trial looking at, it's a meta-analysis of the recent randomized controlled trials of putting in mesh at the time of a permanent colostomy. And because of the high incidence of peristomal hernias and the difficulty of fixing them and the high recurrence rate of fixing them, people are really looking for a way to prevent them from happening. But there have been some randomized studies recently that don't support putting in mesh at the time of colostomy placement. So this group pulled together these studies, 3 laparoscopic IPOMs, 6 open, and 2 with both approaches. And initially it looks pretty favorable, right, with an odds ratio of 0.27, so reducing by 75% the risk. Also, that was in clinical findings and then radiologic findings. However, when you look more closely at their data, and they pulled out the studies that weren't as, didn't have as much bias, right? They had a lot of heterogeneity, and when they pulled out the bias, that nice finding they had of the no mesh having a much higher rate here, you see 15% and 34% in the clinical study, it actually disappeared. So we still don't have the answer for this. It needs a lot more study, and if anyone out there is motivated, it is still an area that's unanswered and ripe for future presentations at SAGES. I just want to talk about one last quick study. I think Dr. Mellinger's talk yesterday was really affecting, if you watched it, when he talked about social justice. And I think we don't talk about that in terms of the materials we use very much. A lot of us complain about the mesh we have and the things we have in our OR, but any of us can walk into a core and have anything we need, right, in all of our hospitals. And if you've ever worked in a low resource area, that is not the case. And in this particular study, the background is that in Uganda, most of the cases, most of the inguinal hernias done there are a primary repair with no mesh, they're actually not done by surgeons, and those patients are in the hospital for 4 to 5 days. And so looking at that environment, this group, which was 2 Swedish and 2 Ugandan surgeons, they were looking at the use of mesh, doing a standard Lichtenstein like we would all do in this environment. But they needed to be more cost effective for this population. And so they used the mosquito netting that Andrew Kingsnorth has been talking about. And they trained their nurses how to wash and sterilize it and cut it up into 10 by 15 centimeter pieces, and they made sure that they were autoclaving it correctly. And they compared it to a standard hernia mesh we would use out of the package here. And the cost difference was $1 versus $125 for the mesh. One interesting thing to know is that 40% of these patients had big scrotal hernias, which explains why when you look at the findings, they had a lot of hematomas or swelling in the groin, but they had 1 patient recur. I mean, they had good outcome and, over 300 patients and a 0.7% recurrence rate. So any postoperative complication was about 30%, but most of these were from the big groin hernias. I think this is really thought-provoking. We are just kind of used to spending as much as we want. And when they followed up this study and they looked at the cost difference of $124 and the quality of life, it doesn't sound like a lot of money. I think my team wastes $124 every time they open extra stuff I don't want on my back table just in case I want it. But when you look at Uganda, the per capita healthcare expenditure is $59 for a patient for a year. I mean, that's a huge deal. And that's a lot more people who could get better hernia repairs. So thank you very much for the time.